Thank you so much, Monica, for that wonderful introduction. I am very stoked to be here to talk about something that I love and have been dedicating almost 3 years of my life to since the pandemic. So, without further ado, I'd love to start this talk to kind of break down what we will be discussing today. I'd love for you to take away learnings as you find them useful. And I always like to start off these talks with stories to put into context about what drove us to work on the patient led research collaborative, what were the pain points and the opportunities for innovation. And then we'll break down into the components of the patient led research model that we follow, and as well as what's working for us, what we're currently dedicating our energy and time to. And I know a lot of you watching are uh, builders, systems builders, and bioinformatics specialists. So I want to conclude this talk by kind of taking the vision of the patient-led research collaborative and what we've done, and turning that into concrete needs and asks going forward from folks like yourselves. Um, so starting off, before the pandemic, I was a computer scientist who dabbled in field research, working on plenty of digital products for international clients. And my role was to be on the ground with teams in these frontier markets to make sense of how people were using a product and then compile these insights for these directors and C-level executives all the way back in Palo Alto or MIT. And it's so often the case where the decisions that are being made on the ground are very different than the decisions that are being made in the boardroom, um, where the data lives on opposite sides of the world in completely different contexts. And I want you to remember this point because we will come back to it later. I love my job and I love tracing data back to its source and uncovering opportunities as a field researcher. The source of my data are people and communities, not code in a repository. But this story then is about the patient-led research collaborative and how the people in the communities banded together to fill a gap, and how this is a precious opportunity for us to innovate on how we do science. So going back to March 2020, I just returned from a business trip in Taiwan, and my life took a 180 turn at that point. I had gotten progressively more sick, and I came down with chest pains, heart palpitations. I was struggling to breathe and stay conscious, and my blood oxygen was hovering below 90%. Um, on March 21st, I found myself in the emergency room and I found myself quarantined in the company of others who struggled just like me to stay conscious. And remember that time, the supplies ran low. There were no oxygen, there wasn't even testing. With an x ray, they did find damage in my lungs, enough to warrant treatment. But because there was so little capacity, people like me, one by one, were sent home to isolate and tough it out. Nobody followed up. I was on my own. I was pretty traumatized by that experience. And over the next 6 months or so, I struggled with shortness of breath, debilitating fatigue, memory loss, chest pain, rashes after physical exertion, and on the symptom list went. And just like that, I went from a healthy 30-year-old who built my identity around being a global citizen and researcher on the ground to being disabled and homebound. As I struggled, I was also paying attention to what the media was saying and what's the dominant narrative out in even research was saying about COVID and how mild it was and how it's only a respiratory disease and how it only affects older populations and how people will recover within 14 days. And I remember at the beginning of this pandemic, a lot of young and healthy, quote unquote, young and healthy people like myself experienced something very similar, but without the belief and support. So I realize in hindsight, I do this thing when I'm struggling, and maybe some of you might relate, is that when I'm facing with a difficulty, my intuition is to organize, is to build things. So I started sharing my experience getting sick and getting care on social media. I gathered data on myself and my symptoms. And I did this for two reasons. One is to find support, the other is to potentially save my life. In the absence of a clear diagnosis or a test, I realized that if my condition worsens, who would believe me? How will I be able to describe it? So I started a spreadsheet to track my symptom trajectory and shared this template publicly in a project called COVID Practical Home Care. The screenshot on the right, it's a giant Notion repository in which I gathered hundreds of opinions and best practices from fellow patients and put it together into this home care document that I shared with anyone and everyone who had gotten sick. Um, and one person came back and told me that she took her spreadsheet. I shared the spreadsheet as well, and I made it so that other people can fill out their own symptoms. And one person came back and told me that when she filled out her spreadsheet, she took it along with her to the emergency department one day when she had concussion-like symptoms from COVID, and she was too incoherent to present her symptom history at the time. The nurses were so impressed that she came prepared, and as a result, she managed to get triaged quickly and get treatment. And I came to realize that clinicians and care providers welcome this type of self reporting. I also realized that patient generated data is helpful feedback for other patients as well. So, I joined a support group because of this, called the Body Politic, that's made for and by long COVID patients. And it's founded by an author of this New York Times op ed called "We Need to Talk About What Coronavirus Recoveries Look Like." Um, at this time, there were a lot more people speaking out about um, their lack of recovery. People on Slack weren't just looking for moral support, but also answers to ongoing and strange symptoms. So I shared my tracker there as well. And to my surprise, people already knew about it. Patients were very proactive, and patients are still very proactive. We have this channel called Data Nerds, and it's exactly what it sounds like. Participants are usually in STEM with research and data analysis backgrounds, and people here track the latest research, discuss hypotheses, possible treatments, and compare notes on data. It was here that I met like-minded co-founders and now friends who saw just how much data we are all sharing and producing and decided to do something about it. And that's exactly how the Patient-Led Research Collaborative was born. We formed a team in April 2020, and we designed a survey within a time span of about 2 weeks. um, we worked day and nights, and you have to understand we're a bunch of sick people who aren't able to work, and there's really nothing else that's more important than trying to come up with answers for ourselves. So we published a report detailing symptoms from 640 people who responded to our survey. And within uh, this population, we detailed people who have either tested negative but still have persistent symptoms. We found out that a lot of people who didn't have access to testing had the same kinds and the same nature of symptoms as the folks who have tested. So the screenshot on the right shows that people who have been tested, um, the mean time was about 4 days in. The people who haven't been tested, the mean time is about 16 days in. Um, and so we found high prevalence of cognitive symptoms in the form of fatigue called post-exertional malaise. Nobody was asking these questions to patients. Nobody was asking, did you have access to testing? Nobody was asking, did you have cognitive difficulties? And when we put together this survey, people felt that their conditions were finally validated. This was a time when we also started getting calls from CDC and other public health organizations. And soon that ballooned into a bigger survey. We thought our work was done, but it wasn't. So we conducted a bigger study, follow up to the first one. For this one, we got IRB. It was over 7 months of symptom history, with a similar study design, which is self-reported data from the patient population. Um, it was published in eClinical Medicine July 2021, and we surveyed nearly 4,000 patients, majority non-hospitalized, about 20% were healthcare workers. It was a huge community undertaking, and we translated the survey into 9 languages, and the study has over 1,200 long COVID respondents, from which we analyzed only about a third of them. And they come from 56 countries, so this was an international study. Um, and I just wanted to go into some of the findings of the patient-led research that we've done, just to give you some more context into long COVID and why it matters so much. One of the biggest misconceptions about long COVID is that it simply is an extension of the acute COVID symptoms. But in our data, this is not the case. And now we know more about the pathophysiology of long COVID. This is absolutely not the case. With the longitudinal data that we gathered from our teammates, we did some analysis, some clustering analysis, and we found there are distinct clusters of symptom presentations over time. So it's not only that the acute symptoms drag on, but they're over time, if people do not recover properly, there are new symptoms cropping up, and this you can see in cluster 3 very prevalently. Um, when people completed our survey, we gave them the option to also download their data. And this was very intentional based on my personal experiences of sharing my symptom tracker sheet. This mechanism allowed people to also communicate with their care providers what's going on. Um, with the survey developed by patients for patients, for example, you have terms, patient specific terms, like, for example, brain fog. People will say, I have brain fog. But if you go to your doctor and say that I have brain fog, you're much more likely to be dismissed. As patient researchers, we understand that brain fog can translate to vertigo, to memory loss, concussions, brain damage. And so, in order to make this survey accessible, we have these patient generated terms, but we also map them into clinical language for anyone who is doing analysis on the other side, or in this case, communicating with their care providers. So I think one of the biggest impacts that we had from doing this study was that collaboration started pouring in from more traditional institutions. We were invited among other patient researchers and many clinicians across the world to help the WHO form a clinical case definition of the post-COVID condition. And it came in the form of a Delphi consensus, which was really interesting to me because I just nerd out about democratizing the process of coming up with clinical definitions, and that was a really cool example. Some of our study findings are reflected here, and with this output, we encourage practitioners to use this inclusive clinical case definition to diagnose long COVID. As time went on, we got even more collaborations. And today, we understand that long COVID is a debilitating illness that occurs in at least 10% of SARS-CoV-2 infections, more than associated with more than 200 symptoms. It impacts multiple organ systems. At least 65 million individuals worldwide are estimated to have long COVID, and the cases are increasing daily. The pathophysiological mechanisms of long COVID are quite complex, and it's listed in this paper that my my co-founders co-authored and published in Nature Review not too long ago. So I wanted to go back to our team. When we started this project, we were a bunch of sick, unpaid, struggling volunteers who had a lot of questions. And as I said, honestly, I thought after publishing one report, mostly over Slack, we would pass on our batons to teams who have much more resources to carry on the work. I honestly thought that the patient-led research team was going to be obsolete. We didn't even have a name back then, obsolete in 6 months or a year. And we would all have effective access to care. We would have access to treatments. Our doctors will be trained, and we would finally have some answers. And looking back and thinking about this time, I thought, wow, we were so naive, because instead, our team, we found a lot of demand for our expertise as patients and researchers. And we needed to come up very quickly with a way to shape our roles in long COVID research that rang true to our values as an evidence driven practitioners, but also accountability towards the patient community. And so let's get into the next part. And I'm very excited to present the patient led model. But before that, I want to kind of frame the conversation a bit with the problems that we see with open science models and from our perspective. This is a paper that we quite like called The Peer Production Practices, Design Strategies in Online Citizen Science Platforms, published not too long ago. When we get approached for collaboration as an organization, oftentimes our involvement in the collaboration is confined to a specific time and place during the research process or any process that the collaboration takes shape. Some easy examples I can throw out is that patients like ourselves are often recruited uh, for disseminating research, for example. Like a study has already come out and this team contacts us saying, hey, I think your population will be excited and interested in this here. Please be our marketing team, right? Or teams might contact us and say, hey, we need help recruiting patients for this study. And you see this quite often. Can you send out this flyer to your group? Please be our free marketing team. Again, you see a pattern, like patients are pigeonholed into certain tasks, and we call this collaboration for some reason. Or, I think something that's more relatable to folks who are more on the technical side is somebody builds a platform, and it's an open access platform, and asks patients to sign up and use it without ever understanding why patients would sign up for it in the first place. And so we see these problems as both frustrations, but also opportunities. Um, as a collaborative, having done our own research and carried it all the way through to publication, we want our involvement with partners to transform from a contractual model to a peer production and co-leadership model. And these are big words, but I will break them down into concretely the strategies in which we employ to do this. Um, and so this to us is democratizing research. If you look at this chart on the left here, it goes from crowdsourcing tasks to peer production, and we want to sit at the top of uh, this this ladder. So why do we do this? The patient-led research model is built on top of several goals that we have for ourselves and for the patient community. First off, we want our research to be based on emerging priorities that directly serve patients. And I can give some examples where it doesn't. So, for example, the um, there is a very strong drive within our space to frame long COVID as a psychological phenomenon, that patients are imagining themselves to be sick. And this doesn't serve our community needs and agenda because patients within our community need more um, need more medical care, right? They don't need to be told that their illnesses are not real, and I think this is a very obvious phenomenon when you have a chronic illness. Um, and so we support research agendas and research goals that are based on biomedical science because these serve emerging priorities. Our goals are also community focused. And so the patient community raises questions based on lived experiences, very similar to how we did things in the beginning, where people would surface their lived experiences on Slack. We just help to scale this out across a lot of other communities. Patient researchers transform them into research hypotheses, and I will get into how we do that. Um, Another one of our goals is to be collaborative. Patient researchers and academic collaborators co-design studies and conduct data analysis. This ties back to not pigeonholing ourselves into only contributing at any given time or place. And last but not least, we want our work to be impact driven based on this patient led research model, that we disseminate research into not only open access academic journals so that it's easy for any researcher to pick this up, even patient researchers who are not affiliated with academic institutions. We spread our work on social media and reframe it in a patient friendly context, and also in front of key decision makers as well, like the WHO, CDC. Um, Now I want to this is a very intimidating chart, but I want to spend some time getting into the structure of the patient-led research model. And one of the key components of it is integrating uh, patients into the research process. And what you're looking at here is actually a playbook and a scorecard that our team developed in collaboration with the CMSS and with funded by PCORI, uh, in order to tease out what are some of the ideal ways that patients can collaborate with research partners. So I want you to all just pay attention to the last column, which is the ideal collaboration model. And this is the one that we practice and aspire to, right? And going down the rows, it's broken down into phases of the basically the research process, starting from hypothesis all the way to publication. We added attribution down there because that's very patient. That's very important to the patient community. But basically, I'll run through each of them and kind of describe within the patient-led research model how we do things a little bit differently. So first off, the hypothesis generation phase. Research goals are based on patients' priorities and co-written by patient organizations or patient researchers. Our inquiries and lived experiences share an equal weight with research organizations' interests when generating research hypotheses. So, what this looks like in practice is that patients develop guidelines for hypothesis. We go out and we solicit hypothesis from a patient and research community. This is one of our projects called the Patient Led Research Hypothesis Project, which does exactly what it sounds like. Then we have a patient panel that we selected to look at the hypothesis, assess the evidence based on what we know from other post-viral illnesses, but also the domain expertise of the people on our panel as well. We sometimes also bring on external experts to help review, and we vote for the hypothesis to move forward on to publish. Um, we the team then collectively refine hypotheses, and sometimes we have partnerships to present them to external science panels to get even more feedback. So it's a very iterative process, but it's also heavily embedded in patients' lived experiences and also the domain expertise that our patient panel has. And the results of that is what we're currently working on right now. It's one of the projects that's on my plate, is to publish these hypotheses into open access journals and disseminate them into the patient and research community. Um, these are very I think are very well thought out, well written hypotheses um, that are presented alongside with the suggested study design, with unanswered questions for researchers who wants to take this on. And so this to us is patient led because we not only surface our priorities, but we help guide uh, the research teams who eventually will hopefully take on uh, the hypothesis that we generate and incorporate them into their studies. So going down the process from hypothesis generation then to study design. Study design for us and for our internal projects are co-written and reviewed by a diverse array of patient researchers representative of the study's populations. This is very important to long COVID in particular, because long COVID has quite a few, I would say, phenotypes, and you have folks who are very severely disabled versus people who are more mild and have organ damage, for example, in certain organ systems. And so it's important to write a study design that incorporates the representations of these subpopulations that are applicable. What we also advocate for is to test the study protocol with the patient community. And this is something that Patient Led Research Collaborative offers. As somebody who has done quite a lot of field research and participatory design, this is something that I'm very passionate about. And when teams approach us with a study design, we actually offer to say, hey, we can recruit 5 patients within our community to run uh, this pilot with you, and we can use that to refine the study design. This to us is open collaboration. This to us is open science. And so I think I'll share another example of collaborating on study design. This one comes from one of our projects where we helped a team who is developing a treatment protocol originally to treat traumatic brain injury. Uh, but now they want to repurpose this rehab for long COVID patients. They have a lot of data from their previous patients, and they have developed this uh, common cognitive complaints after COVID inventory. So this is an instrument to assess these participants, how well they are doing cognitively and where the needs are. And so we've been invited as partners to co-develop this protocol, and where we help to refine the questions that are being asked of patients uh, is how people are being tested for cognitive disability, when to offer treatment, when to offer follow-up. These are all very embedded experiences within the patient community, and they can be surfaced to help create a more holistic study design that better targets this population. And the result is having not only having a survey, uh, this instrument that is targeted to long COVID patients, that is very publishable, but also to be able to have participants with the right kind of challenges that are suitable for this study. This saves a lot of time, a lot of headache for the study administrators, and it also makes the experience on the patient side much better when they have a more targeted treatment that's well vetted by the patient population. Moving down this list into co-analysis, I feel like this part is something that the patient-led research collaborative does um, quite well in a lot of domains because our team is multidisciplinary. Um, Patient researchers work concurrently with research partners to carry out data analysis. In the case where it is an internal project, we co-lead on the interpretation analysis, and often bring on patient researchers who have domain expertise to lead the project. Um, and so I don't want to go too in depth into examples for this one because I think there's a lot of opportunities for you all to ask questions here. There's so many examples that I can give that I'm not sure which one to talk about. Um, but I will also say that, you know, in a lot of cases, I think even folks who are very pro open science, open data, don't really think in this direction. And if you look down this row to the left side, you know, you have cases where patients do not have input in what data to prioritize for analysis and or the methods for the analysis. We also have cases where patients are asked to review drafts of manuscripts, but have little say in what data to prioritize. Um, or we have cases where, you know, patients are asked to give input, but it's a last minute thing. We don't have time to do our own research. We don't have time to bring on our own experts. And so it kind of puts us in a difficult spot to collaborate if we were not brought on early and given the decision making power. And this is kind of the the pattern that gets repeated, bringing people on early and giving decision-making power. Um, I want to touch briefly on accessible publication. Uh, Study results are freely accessible to patients and the public has been one of our major drivers of being able to disseminate uh, messages, but also research that are relevant to the patient population. Findings that are summarized in lay terms are actively disseminated to the patient population. So what we've been doing is to create Twitter threads of our papers. Uh, we also send out from time to time newsletters to break down what certain analyses mean in lay terms and have the person who has done the analysis themselves explain that in lay terms. And obviously, it's uh, reviewed by patients before we send it out so that we understand that this the level of understanding is accessible to all. Um, we also advocate for having a channel communication that is available for patients to ask questions. Sometimes uh, disseminating research can be a very one-way thing that we saw teams do, and it's very hard when the patient population knows a lot more and has a lot to say, but doesn't have the means to communicate that. And so for us, we always encourage people to email us, encourage folks to ask questions when we present these in talks, um, and it just to help to build trust. So I think well, we have two examples, but one example of accessible publication is something that we've seen um, our partners do. Um, we've seen folks invite, you know, patients to oops, sorry. We've seen folks invite patients to review their manuscripts before publication. Um, and we've seen folks invite us to uh, write chapters of books that are both meant for patients but also researchers. And so it just helps to tie together um, the patient community but also the researcher community to speak the same language. And I think the dominant theme here is to create a model where collaboration between academic partners and patient partners are meaningful. Um, and this patient-led research model, as I said, we actually develop a playbook with the collaboration with the medical specialty societies to present what is the ideal collaboration and what is acceptable collaboration. Um, and some of the dimensions that we teased out through this process has a lot to do with um, how decisions are being made and when they are being made, and how this implies in regards to leadership structure and how well informed groups are about proactively addressing issues. And I focus particularly on the research process itself because we are a technical audience, but I also want to stress that the governance portion is equally as important in order to have an open model. Um, this scorecard playbook is accessible on our website, but also the Council Specialty Society's website, and I'll share this link with anyone who is interested after this talk. I kind of want to like conclude this talk with one of my favorite memes from the chronic illness community. Um, the chronic illness patients from HIV, Lyme, ME/CFS communities that are adjacent to long COVID have been dealing with these same issues of dismissal, uh, of not being invited to the table to make decisions, of having a wealth of lived experiences, but not having been able to make use of them, or have been respected for decades. And I think because the pandemic is such a international uh, and in such a proactive thing that's on everybody's minds in the research space, in the academic space, it's about time that our insights, experiences, and voices are at the forefront of making progress. So I think what I'd like us to take away from this experience is that um, open data, open science to me isn't just about sharing code and throwing it onto a GitHub repo. It's also about sharing power and sharing decision making. It's also about the strategies of doing that. It's about the values of doing that. the pandemic has created this urgent and innovative environment where we should be asking each other hard questions and collectively redefining what equitable science collaboration looks like. And I believe we can do a lot better. So I want to end this talk with a quote that's shared with me in an interview with a patient leader of another chronic illness community. Um, that the data oversight, the lack of agency and collaboration, missed opportunities are fixable if we break the silos early and we use the collective wisdom at the source of the data, which is the people and the communities. The only thing that's better than a voice is a vote. So, lastly, I want to put the spotlight on my wonderful team. These are all people with long COVID, and it's really been a pleasure to work with folks from all stripes of life. I myself barely graduated with a bachelor's degree. I actually quit school to do another startup. And so it was really interesting to work with people who have PhDs, but also folks who have quite a lot of industry experience and folks who um, don't come from an academic background at all. Want to shout out to some of our collaborators that we've had the pleasure to work with. Um, Even though this is a hard space to be in, we can't move forward without collaboration. And last but not least, thank you for coming to this talk. We are at patientledresearch.com. Um, I'm Hannah Way at patientledresearch.com. You can check out our website. We can follow us on Patient Led and feel free to ask any questions. All
Thank
right.
you so much, Hannah. I would love to hear the applause that is going on with our the one thing about our webinars, any webinars, is that you don't get to hear that appreciation. But thank you so much.
Of
This is
course.
fantastic. And so we already have one question I'd like to read, and then yeah, just welcome anybody else to please type your questions on the Q&A. So the question is from Hervé Ménager, and he says, "Does the patient-led research collaborative have members?" He
Yes.
apologizes if this is answered. Go ahead.
Yes, we are from 4 continents. I myself am from Canada. Um, our one of our lead scientists who you saw did the clustering, they were from the UK. We have our reinfections lead is down in Brazil. Um, just last week we were down in Mexico, and so we are we are quite global. We do have a strong presence in North America because the advocacy is quite centered around here, but we are global.
Thank you so much. And thanks, Hervé, for the question. Well, I have a question for you about one
Hmm.
of the you were sharing at the end. Thank you so much for highlighting that your patient partner governance is also an open process. And I was wondering if you would be able to share a little bit more about the details of your efforts for transparency and openness as you establish these governance practices.
That's a really good question, and that's something that we're constantly innovating and trying to figure out. Um, our governance structure, we are co-led by 4 individuals who share leadership uh, responsibilities. So we have a lot of overlapping roles. We don't have too much hierarchy. Um, and between the 4 of us, you know, at least one of us is on every project team. Um, and with that said, you know, folks in the collaborative, we're now about over 45 people, so almost 50 people. Anybody is invited and encouraged to participate in a project, but also if they have their own projects, say if they're tied to an institution, they want to run a study, they can borrow resources from the collaborative. It's just that one of the leads has to be on the project itself, just to like oversee the division of labor and resources on in the collaborative as a whole. So we try to decide things uh, by vote for org level decisions. We also try to bring on diverse voices to lead projects that um, directly impact their community. Um, so we try a bunch of things. I think that's I don't want to ramble too much on
No,
about our governance structure, but we try a bunch of things.
thank you so much. This is great, Hannah. I'm always looking for ideas, and I really appreciate you sharing a little bit about how this team is co-led and how you share the responsibilities. Thank you. We have some more questions. So I'm going to share a question from Harry Caulfield. He
Mhm.
says, I've heard some crowdsourced data annotation projects, from some crowdsourced data annotation projects, that much of the community effort was contributed by retired nurses, perhaps due to having the right combination of skills and knowledge. Is that the case in the long COVID patient research community as well?
Yeah, absolutely. I think this is true for a lot of especially chronic illness communities that people who are in this space have been in this space for a while. For the COVID community, the long COVID community in particular, um, as I mentioned, 20% of our survey respondents are from the healthcare space. And so if you look at the data from initial uh, COVID infections, a lot of them were from healthcare. And so these people have healthcare backgrounds coming in, clinical backgrounds. Um, we also, very unfortunately, I mean, a lot of uh, academics are drawn to our work as well, simply because they can't work the hours of being a full-time academic researcher or professor. Like imagine having long COVID and working working in academia. I can't. Um, and so we have folks who either volunteer their hours or are paid by us through projects and grants to the patient-led research collaborative, um, running our projects and contributing data analysis.
Wow, that's incredible. Thank you, Hannah. Thanks for sharing that. Robert Lehman asks, can you talk a bit about patient collaborations around research that it's less directly supporting patients? For example, he says, we worked a bit on making research on long COVID easier to find. Helpful, but clearly not as a high priority as identifying mechanisms.
Hmm, that's a tough question. Um, Because I think our collaborative, directly selects projects to work on based on how impactful they are to the patient population. We have seen repositories, funded repositories on, uh, knowledge synthesis, knowledge translation, and I think it's sort of like adjacent. How they framed it is like this is something that your team can use if you so choose, want to use it, right? And I think a lot of times the gap to bridge here is to building the community trust. Is to, for example, if you're working on something like this, it would be meaningful to have a steering panel of patients to develop some needs and priorities that may be relevant in the end product that you're developing. So what I can think of, for example, is that you know when I'm trying to think of like a real example that's helpful to you. Um, when patients are brought on to some of these panels, one of the questions that gets asked is when you go to a care provider and they disbelieve you, for example, what kind of information would you like to have with you, right? And this speaks to informational support. And a patient can tell you that, well, it would be helpful if the evidence that you provided also tied into a a, a doctor's name, for example, somebody who directly practices uh, what what this research is advocating for. And so when they go into the clinic and they present this evidence, right, the doctor can be like, "Oh, I see another doctor's name on here." And they can call them up, if they so choose. It's just more there's more authority in the statement. And so I think that's a very specific and concrete example, but I think that's sort of the direction that we think of when we try to approach these problems.
Mhm. Thank you so much. Ido Friedberg has a couple of questions. I'll start with the first one. Ido wants to know how much have you been able to learn from other groups? Ido, I assume you're talking about chronic fatigue syndrome patients as an
Mhm.
example here, in terms of organization and advocacy. So, have you been able to learn from such groups?
Yes, absolutely. I think the MECFS community has such a wealth of information on advocating, on organizing. The pacing guideline that we refer to is developed by ME Action, and we work closely with them on advocacy. I'm not the best person to speak on advocacy because most of our advocacy is conducted in the States, and that is a very fantastic internal PLRC team that does that work. But yes, we collaborate quite closely with ME communities, dysautonomia communities, to be on advocacy calls. We collaborate to write letters and join movements, and so I think we stand on the shoulders of giants when it comes to advocating for um, better care for both MECFS, long COVID patients, and related chronic illness patients, because a lot of what we go through, a lot of the disbelief and challenges are very similar.
Thank you so much. And Ido has a follow-up for
Mhm.
this, so I'll read this one as well. So he says, "How are you managing the contrast between data sharing and HIPAA requirements that may hamper that sharing that is required for your research?" And he just wants to clarify, this is Health Insurance Portability and
Mhm.
Accountability Act of the United States. So yeah, do you have some thoughts on how are you managing that contrast between possible requirements here in the US that may hamper sharing the research?
Mhm. I think most of our well, all of our data, internal PLRC data that we gather from patients are patient-reported data, so we don't take EHR data, which will run into that problem. But we do collaborate with teams who use EHR data, who use lab results and direct, they store their data in their database, and, um we develop data sharing agreements to either borrow anonymized data, and we give them anonymized data, for example. So we find ways to get around it. Like our organization is not structurally set up um, to host like patient data to the extent where these large institutions are.
Thank you so much. You've been so gracious with your time. And we have one more question that I think we can run. Robert again asks, can you talk a bit about the expectations around financial support for collaborations? Ideally, academics would bring some support through grants,
Yes.
through that's not always possible.
Yeah, wow, this is another talk. Um, because I'm very passionate about making sure that our model is both sustainable, but also we have some leeway to be innovative in how we both take money and use money. So um, it's really interesting getting into the space of academic funding because we're not directly associated with an academic institution. I mean, we have members who help us get IRBs, who have ties with academic institutions, who can pull us into co-write grants, and we have a lot of offers from collaborators who do the same. And so we try to piggyback off of existing institutions. Um, in in regards to expectations, it's definitely a very difficult place for our collaborative to find funding that's directly targeted to our kind of institution. And so we have several models that we employ. So first is the co-writing grants with existing institutions. And the other one is going after foundations. We're a nonprofit. We're nonprofit status now, so we can go after nonprofit funding, and this is mostly org level funding, not project level funding. The third is like alternative ways of funding, so crowdsourcing, cryptocurrency, like a big venture capitalist who happen to have somebody who's sick and they really just want to, they really believe in our purpose. So we're still exploring ways to support a collaborative like this, but it's definitely a challenge because we don't fit into any neat categories.